Welcome, everybody, to Let's Talk Progesterone, Demystifying Delivery Modes. We have a very prestigious gathering here. We have Dr. David Rosensweet. We have Dr. Holly Papanek. We've got Jill Chmielewski. We've got the absolutely phenomenal progesterone global expert, the pharmacist Carol Petersen. We've got a bunch of people from the pro level, and we've got myself, Dr. Lindsay Berkson. And we're going to be doing a roundtable on progesterone. It's basically a conversation about delivery modes, which way you take hormones into your body, and how do these delivery modes affect safety of breast tissue and endometrial tissue, because there's been some discussion on Instagram lately saying that oral progesterone mainly gives you mental benefits, the production of neurosteroids, but not necessarily progesterone, breast, and uterine protective benefits. So we've decided to talk from our understanding of the literature and also our experience of working with patients. And Carol has experience of many fertility doctors working with delivery modes to help the patients get pregnant. So welcome, everybody, and thank you for giving your time to do this. I'm just going to do a few slides here to start this off, and then I'm going to want to put out the question and have us start to have the conversation. So here's my slides. So it's Let's Talk Progesterone. Progest got its name because it supports pregnancy. Pro to support, gestation is a progestation hormone. So we really want to know if we're taking oral progesterone, does it have really healthy effects that could allow a uterus to sustain a pregnancy? So which delivery modes, and we're going to focus on oral and topical and vaginal, those three major delivery modes, signal the two progesterone receptors, PR alpha and PR beta, which protect, if all of them or none of them protect breast and endometrial lining. We know when we first started using estrogen in the 60s and 70s in Britain, all by its lonesome, that there was an increase in uterine cancer because progesterone gave growth signals to the lining of the uterus. When they added progesterone, it had opposition or growth controlling signals that protected the uterus. So our endpoints of this discussion are: which way do we take progesterone into our body, and which of these delivery modes protects both our breast and our uterus? And I'm going to just open with that. I'm going to close my slides here for the moment, and I'm going to say, Dr. Papanek, will you share what we were talking about just a few moments ago of what you found in the literature?
Sure. So one of the larger studies in women regarding, I found oral progesterone. Let's make it very clear, we're not talking about progestins. Pet peeve when we put that overall cloud. Those are synthetic. They don't act anywhere near the same. And in the words of Dr. Dash through Carol Petersen, those are foreign monster molecules. So we are talking about body identical progesterone. The 80,000 woman study, it was part of the E3N cohort. They looked at this, and they looked at oral progesterone in particular. There were three arms. There was the estradiol or E2 arm. There was the topical estradiol. There was topical estradiol with progestins. Don't ever use those. And then there was topical estradiol with oral progesterone. And what they found, not only were the levels such that when they measured them in the serum, there was progesterone there, right? So we can capture that on serology, but we're looking for end organ or kind of end point, like Dr. Berkson said. How did it affect the tissues? And what they found is the estradiol topical and the oral progesterone had a significantly decreased risk of invasive breast cancer.
Which means the progesterone protected the breast.
Exactly,
right?
Exactly. So we have, these three arms, and this is the only arm that resulted in it. So clearly, not only do we have it measured in the serum, we have end organ tissue, demonstration of that. So I really like that study. I thought that was very helpful. There was one tiny progestin, hydroxygesterone, which I'm not even familiar with, which also had a very slight decrease. But all the rest, including Provera, which is used most in the U.S., had an increased risk of breast cancer. So again, kind of looking at this, but that is a pretty decent and very large reputable study, 80,000 women with clear implications that the progesterone is not only present, but it resulted in an end organ or end target change.
So you're saying that synthetic progestins in most studies, as in this one, increase the incidence of breast cancer. That's why birth control pills, which are made of synthetic progestins and synthetic estrogens, increase the risk of breast cancer. But natural progesterone taken orally made it to the breast, bind with the progesterone receptors in the breast that controlled growth and reduced the incidence of breast cancer.
Of invasive breast cancer. That's exactly right.
Excellent. Excellent. Does anyone else thank you so much for sharing that French large cohort study. You know, we forget about how much the French have been using bioidentical progesterone for many, many years. And they show that oral is very protective for both the breast and the uterus. And they also show topical is protective, and it depends more on the duration that you continue it on a regular basis than even the dose. Does anyone else want to make a comment? Carol, did you want to speak about your history with fertility docs?
Well, my history is a lot tied up with Dr. Katerina Dalton's original work on PMS and the effectiveness of progesterone and large doses of progesterone. And ultimately, as we were compounding, fertility doctors were turning to the oral capsules because the alternative at the time was injecting progesterone 50 milligrams IM every day to maintain your pregnancy. And the women would certainly do that when they cared desperately to have a baby. So we found that capsules, the oral capsules, certainly did exactly what it needed to be doing to support a pregnancy. And the doses at the time were either 400 to 600 milligrams capsules in oil in divided doses.
Oral.
Yeah, we have so much confusion around progesterone. I'd like to say one big bugaloo, I believe, is that oftentimes it's not taking into consideration that the amount of progesterone that you're using at a particular time, it has to be considered along with the dosage form. I saw a PMS study once, and this was oral, and they used 200 milligrams 10 days for PMS patients, and said it was ineffective for PMS. Well, this was far below Dr. Katerina Dalton's and our starting doses with the capsules. Yet this gets into the literature, and now suddenly oral progesterone is ineffective for PMS. We get a lot of these. I've seen studies that compare like a few milligrams of oral progesterone to 80 milligrams. So you got a couple hundred oral, then you have 80 milligrams of the topical, and then the topical doesn't perform as well. And in this particular study, so they throw it out, say, oh, you can't use topical progesterone, it doesn't work. I don't think it's a dosage form. I think it's ensuring that each person is absorbing and using what the end product is. You can put progesterone in a cream directly on the breasts, and you can get resolution of sore, tender breasts within a day. Tell me it doesn't work.
Dr. Rosensweet, I'm glad we heard your laughter. If you don't mind, we're going to go to you for a moment, and Carol will definitely be back. So, Dr. Rosensweet, you've created the menopause method, which is an enormously brilliant method of topical delivery of hormone in a specialized patented oil that doesn't have any adverse chemicals in it. And why don't you talk about the protection of the two endpoints, breast and endometrium, with topical progesterone?
Thanks. Well, in general, I like to think, what was the original design of the human female? And every young woman, something that many people aren't aware of, produces 100 times more progesterone than she does estrogens, for example. And the outpouring is so robust, and in a healthy woman who's ovulating regularly, menstruating regularly, during the second half of her cycle, she's putting out 100 times more progesterone. This is a phenomenal amount of progesterone. There must be a reason for it. And we know what the reasons are. There's receptor sites all over the body for progesterone. And it's a wonderful balancing to the estrogen. Estrogen stimulatory, progesterone's calming. So estrogen stimulates breast glandular tissue. And if it goes unchecked, without the presence of progesterone, women get painful breasts. they get overstimulation, they get too much cell division in that breast. Whereas when there's adequate progesterone, i.e. 100 times as much estrogen, there's a balancing and a woman doesn't get breast pain during her normal cycle. And I like to carry that. I mean, this is so obvious in just general medicine that's been known for so hundreds of years. The moral of the story is, I'd like to also bring it into the uterus. If you don't have enough progesterone, women bleed too much. They get too much stimulatory effect from the estrogen. Whereas when you put progesterone in, instead of getting PMS, severe uterine cramps, everything calms down. In other words, the female body is designed to have just the right rich amount of estrogen and a robust rich amount of progesterone. And without it, there's consequences.
So does the topical deliver to these tissues?
Absolutely. And we can measure this. We do 24-hour urine hormone testing. It's dose dependent. And, when you're giving something topical, there's variations in absorption. So like just what Carol was saying with the oral, you've got to use enough. So no big deal. We go through a clinical process of starting a woman low on progesterone, relatively low, and we gradually increase it. And what we like to do, I always think in terms for a menopausal woman, that the best dose of progesterone is extremely robust. So what we like to do is march the progesterone dose up, continually increasing. We give it to a woman at night, and if she wakes up groggy in the morning, in other words, she got overdosed by progesterone, which is tremendously calming. And if you get too much calm, you feel groggy. We like to take it all the way up to the top and then back it down. And then when we test these women, what do we see? Just rich amounts of progesterone, or its principal metabolite, in the urine. So you can do this with anyone.
What are the dose ranges you're looking at that achieve this in your women, and the average dose range?
There's a wild variation there, and when you're applying it topically, the biggest variable is how well does a woman's skin absorb. So I've seen women get groggy at lowish doses, like I'd say 100 milligrams of topical progesterone. I've seen women get groggy at higher doses, and I've seen women get groggy at lower doses. So the range is at least, I'd say 30 milligrams is the lowest you're ever going to get a woman groggy, and that'd be very unusual. We like the higher doses. We like 100 milligrams, 150 milligrams, 200 milligrams topically, 250 milligrams. We like the higher doses to get a woman groggy. And the same thing can be achieved with oral. You can start a woman if you want to, on a relatively low dose of progesterone, like 50 milligrams, and you can keep on increasing the dose about every second or third night until a woman wakes up groggy, and you've overdosed her. And then you back her down to where she's no longer groggy. And that's a very comfortable and beneficial dose for a woman. And how high can you go? Well, Carol knows the limits there. I mean, it's such an individual thing. You don't think in terms, we all look human, so maybe we need the same dose. No, the dosage needs and sensitivities are so variable human to human. For example, you can have one woman young and menstruating and have this much estrogen, and you can have another woman who has 5 times as much, and they're all normal. That's a wide range, and that's a hidden secret in medicine, that we're individuals, and there's a wide variation of need there.
So I'm going to pose this to both you and Carol. So how do you know when you've reached a dose, whether it's topical or oral, that you're getting the endometrial protection, the lining of the uterus, and getting the breast protection that you want? What do you both look for? And either of you could start, and the next person after that can chime in.
Okay, I think this is the problem. No matter what dosage form you use, you're going to have to go back and do a transvaginal ultrasound for existence. For instance, if you want to make 100% sure that your dose is doing it. I have to go clinically. If I know this person has enough progesterone to handle things like the tender breasts will go away, the PMS kind of things, anxiety, panic, sleep problems, all these things go away. You can't assume then that you're probably doing a good job with the endometrium. Okay, so one thing that you might want to watch for and be cognizant of is bleeding. So if there is some irregular bleeding. Absent a cause, a knowable cause, you've got to go into the medical system for a full workup. But bleeding can occur. You're using progesterone and maybe you're a little bit, tight in this balance and a big stress comes along. And during this time, progesterone will be diverted to doing other things and will not be balancing that estrogen properly. After the stress has come down a bit, progesterone again becomes secretory for that excess tissue you built up. And you get rid of it. So knowing that in advance, that this is a possibility. Now, if this is a one-time incidence, you're done, fine. But if somebody's continuing on this bleeding pattern, you need to adjust the doses, either down with estrogen or up with progesterone or something of both, depending on the patient, because this is really not acceptable, particularly when you get into menopause. Your endometrium should be quiet. Hargrove and Maxim published a study with 5 milligrams of estradiol, 100 milligrams progesterone twice daily. And over time, they did test the endometrial tissue, and it stayed quiet around 3 millimeters.
Safe. Stayed quiet and safe. So can you address some of the experts out in the field letting women know that the only way to get excellent bioidentical hormone replacement is if you have a monthly bleed?
Go ahead.
Can I back up and just add to what Carol said?
Please do. It's a conversation. Go for it.
Yeah, and then I wouldn't want that particular question to go unanswered either. That's a poignant one. I was curious when I first read about Prometrium, the pharmaceutically manufactured, quote, bioidentical progesterone. Yes, it is, but it's got a lot of other stuff in there, that it took 100 or 200 milligrams to adequately suppress the endometrium. And I always thought that was curious. 100 or 200? Why did they just say it took 200? But for about a decade, we did as part of our method, we did annual transvaginal ultrasounds. So the data we had was the clinical data on how a woman was doing, and we had 24-hour urine hormone tests to measure her hormone levels, and we had transvaginal ultrasounds. And what I was astounded to see was there was a very poor correlation between how much progesterone actually showed up in the urine in the form of pregnenolone and the thickness of the endometrium.
How many women were involved? How many women did you do this on, approximately? Just so we have a sense.
Over 10 years, probably 100, 150.
Okay. Thank you.
Yeah. And I thought there would be a perfect correlation. You had to reach a threshold of amount of progesterone, and that would determine how thick that endometrium was. Well, there was no correlation. The best I could come up with was it was a matter of age, that younger women in menopause, they were more likely to form an endometrium if you didn't have enough progesterone, whereas the older women it was very unlikely that you could get them, that they would form a thick endometrium. But it can happen at any age. And I love how Carol said, just look out for bleeding. If you got bleeding, you're producing an endometrium there. And then what do you want? Just what Carol said. You want a transvaginal ultrasound. It's going to show you that endometrium. And what's that going to detect? The rare case, but it does occur, that there could be an irregularity to that endometrial lining, and a woman could have endometrial cancer. So we have ways to detect this. But the bottom line is, I'm going to propose that it's a myth that there's an exact amount of progesterone that if you administer that, you will suppress an endometrium and get a thin, uniform endometrial lining. I'm going to challenge that just from the work we did. Carol, I see you nodding your head.
And there's so much individuality to this. One of our Australian colleagues just reminded us of a menopause article that just was published this month that talked about the absorption. If we want to kind of go back to topical, they were specifically focusing on estradiol. But let's talk about absorption just briefly. Topical with the progesterone, certainly it would tie over. It was based on the Newsom Clinic, which is one of the largest providers of menopause care, maybe in the world. They see nearly 3,500 people a month in their clinic. And they looked back and they tried to look at the absorption, and there's actually a 10-fold range. So you could give somebody 1 milligram or 10 milligrams, and it's just individuality of women. Probably has a lot to do with their skin. We know menopausal skin has a lot of changes. We lose elastin, we lose collagen, we lose epidermal water and such. So, but a 10-fold variation in the dose. So just like you're saying, Dr. Rosensweet, you could give somebody 100 or 200. That's an oral discussion there. But you could also give somebody topical 200 or 2,000. I mean, there's such variation, but it's not that tricky. Just measure it, right? And then look at your end organs, like we're talking about, whether it be endometrial or breast. So
I'd like to break it down to a clinical approach to it is, number one, we do not want any breast tenderness. If a woman's getting breast tenderness, there's overstimulation of breast glandular tissue. And one of the major tools, and not the only tool we have, is to give adequate/robust progesterone. We do not want bleeding or cramping. And so, again, we have the tool. But to put it another way, we believe that a woman should have a rich amount of progesterone for her whole life, and the right amount of estrogen and the right amount of testosterone for her whole life, just to get it simple. And that turns out to be a rather rich amount, but not enough to produce a period. Oops, segue into your next question.
I just want to add one thing before we segue into that, and then I definitely want to hear your comments on those experts that say the best hormone replacement makes you have a monthly bleed like you did when you were young. In that brand new Metabolism of Progesterone article that I sent out to all of you, said that we have enzymes that produce progesterone all over our body, and we also have enzymes that break down progesterone, and fat tissue in particular has a lot of enzymes that break down progesterone. So women who are larger with more adiposity often right there are going to need higher dosages because their fat cells break down rapidly what we're trying to give to protect the breast and the endometrium and all the other global tissues in the body, like the nerves in the myelin sheath, et cetera, the many job descriptions that progesterone does. But who would like to tackle those out there? There's a book that just came out, and there's experts that are saying if you want to get the best bang for your hormonal buck, you should bleed on a monthly basis. Who would like to talk about that?
Talk about that. So this idea came in the early 2000s from a non-medical doctor, and they were giving rather large doses of estrogen to create that bleed. And I had patients come to me that were on that specific protocol, and they weren't feeling well. And so I said, hey, listen, before you go off the protocol, let's do a 24-hour urine hormone test just to see what kind of levels you have there. And we learned through testing 3 different patients that it took 3 to 8 times the amount of hormones, the upper limit, 3 to 8 times the upper limit of the amount of hormones that a young woman had to sustain or reclaim a period. 3 to 8 times, that means a young woman had a certain level of hormones. It took 3 to 8 times the amount to sustain that in a midlife woman. And we believe that was so because of the level of doses. For example, they were using 16 milligrams of estradiol in the mid-luteal phase. Well, my God, our average is 2.8 milligrams of estradiol potency. Well, I saw many people get irate about this. And here's the thing. Every single month, a young woman, when she ovulates, she's preparing for pregnancy, one of the things that's going on is she's also preparing for lactation, for possible breastfeeding every single month. She's producing cell division and new cells in her breasts. And if she doesn't get fertilized, then these cells go away. And many young women experience this. Their breasts get fuller as the cycle progresses. And then if she doesn't get pregnant, the breasts get smaller again and less tender in many cases. New cells every month. And what we don't want to have in a midlife woman is new cells every month, or from the amount of estrogen we're given. This was said exquisitely by Alan Altman, a gynecologist I think he's with either Harvard or Princeton. He published an editorial about this. We do not want this. We don't want breast glandular cell proliferation. There's not a lot of absolute risks for breast cancer, but one of them is increased breast density. We don't want new cells. We don't want estrogen levels that are such that they're going to produce new cells once a month, every consistently throughout a cycle. Now, having said that, you never say never in medicine. So I'm sitting at the National Academy of Science testifying, and next to me is a 65-year-old medical doctor who I knew was on that keep your period going protocol. And I was afraid she was going to testify to this committee that she was on that protocol because I knew it was one of their bugaboos. And she winked at me and said, no, she wasn't going to say anything about it. And then I went out to lunch with her and she told me this story, that when she was 55, she started losing her cognition to the point where she was thinking she wasn't going to be able to practice medicine. And her mother and her aunt, her mother's sister, both had dementia, full-blown dementia. And she knew about the relationship of estrogen to cognition, and she started taking some estrogen. She started clearing up. And she took a little more, and she cleared up more, took a little more, and it kept on increasing until she cleared up totally, and her period came back. And I'm sitting there with tears in my eyes because I know how substantial that is. I'm talking to a living human being who needed to have her period come back. So there are exceptions, and they are very rare, and cognition is one of the exceptions, and very rarely do you need that level of robust. But you can never say never in medicine. No, never. You should never get a period back. But I would say almost never.
Anyone else? Carol, did you want to talk on that? Dr.
Yes.
Papanek?
On this particular protocol, there's a big problem. During the first part of the cycle, it's estrogen only, and estrogen in some really high doses. And the second part of the cycle, you add progesterone. Also, on the number of milligrams and stuff, it's pretty high dosing too. However, I keep running into women who have been doing this protocol and don't bleed, and their endometrium is really built up. And you don't have to have that built up if you pay attention to progesterone the first part of the cycle too.
Can we talk about what that buildup means? I'm not sure everybody understands that.
Buildup of the endometrium. I spoke to a woman the other day. She had her endometrium built up to 15 or 16 millimeters. Huge. On this, like half the time you're on no extra progesterone. And if you don't have that being contributed by the adrenals like it ought to be, the estrogen is unfettered and keeps growing.
This is great. These experts are also saying this is exactly perfect, Carol. And then also, Jill, I don't think you've chimed in. So when we finish this with Carol, Jill, I'd like you to chime in. We have experts, Carol, saying that we should only take progesterone 2 weeks out of the month and not the whole month. And you're getting right to that. Can you please clearly address your thoughts on that?
You want Jill to continue?
No, I want you to continue, and then Jill. I just was giving Jill a heads up.
So this is a very big problem. I had a client briefly who is a physician herself. She prescribed this protocol. She liked being on it. She liked the high levels of estrogen. However, she's got this huge buildup. I encouraged her to use more and more progesterone, and she went up a little, not much. But no bleeding. I think she could probably have gotten there, but she didn't do that. She called the doctor who is the medical expert for this group. That doctor told her to have a hysterectomy. I go, and she was going to do it. I said, this is unacceptable. You don't have to have a surgery for something you're inducing by what you're doing. Well, she ended up having an ablation. Why is she doing that? She could clear it up, and this big problem of this buildup. And I've run into more than one client who has that very problem. They're not bleeding on that protocol, and that excess stimulation in the first part of that cycle, that cycle mimicking kind of therapy is a disaster for some.
So you're saying it's good when you're a menopausal woman to take progesterone all throughout the month, or should people cycle it at all, like several days of a hormone holiday? What do you think of that?
I think you should use it every day. Your body doesn't have an on and off switch, but realize that it's the adrenal progesterone. This is steady state. The ovarian progesterone cycles. Other parts of our body don't go up and down like the ovarian cycle does. The progesterone we can never measure, and that happens to be inside cells, inside mast cells and Schwann cells, and in your brain. We can't measure that, but it's always there, steady.
Jill,
I love that.
This is Dr. Rosensweet's new menstrual cycle, but I want to bring Jill on because we haven't heard your lovely voice yet, so I'm going to do our little yoga bells here.
Yeah, switching, change of the guards.
Yes, changing
this
the
has been
guards.
great because so for those of you that don't know, I don't prescribe because I'm a nurse. I run an online community. I do a lot of education for women. So I'm in constant conversation with women. And anytime something like this is said, especially on Instagram, I get this flurry of messages regarding cycling, like we're talking about doing the physiologic restoration. We were talking earlier about now what's out there talking about oral progesterone, potentially not protecting the endometrium. So having this conversation, I think what I'm gauging from all of this and listening to all of you is it's such personalization. We cannot look at a woman and say, here's your dose, or all women need this dose, or we only need really low doses of progesterone, which I think is often said and told to women, and that they only need it at a certain part of their cycle. So this has just been this chart. Everything you're talking about, Carol, is, I think, so pertinent to the providers on this call, because when a provider just draws a line in the sand and says statement about hormones, it scares women. So we have to be very, very vigilant about what we're saying, what we're putting out there, what we're sharing with women, because it puts women into panic mode. So this is, listening to all of you has been really helpful today for me, and hopefully for the providers and the women that see this call.
The way that progesterone has been used for many decades now is for women who can't get pregnant or sustain a pregnancy. And they've actually compared vaginal, which delivers progesterone exactly to uterine tissues, to oral, and they've consistently shown that oral progesterone, about 400 milligrams, is not inferior, meaning it works just as well as vaginal to support a pregnancy. If it wasn't binding to progesterone receptors in the uterus, we would not see this replicated set of studies. There's an enormous body of replicated studies showing when you swallow estrogen, it can help women who couldn't get pregnant, and it can even help them go on to more live births. That's the big issue. One, getting pregnant, and two, going all the way to having a healthy, wonderful baby. Well, if progesterone orally didn't bind to progesterone receptors in the uterus, we wouldn't see this success story. So it's hard to understand the discussion, and that's why we wanted to have this roundtable to clear it up. But Dr. Rosensweet, and thank you, Jill, for your comments, because women get frightened.
Yeah.
They hear a statement and they get frightened. So we're trying to calm everything down, just like progesterone calms everything down. This is a calming topic and a calming set of agile thinking professionals. Dr. Rosensweet, would you like to talk about your chart here for a moment and how it has been thought of classically, how we make hormones, but the new and improved thought, especially from experts like Carol and yourself?
Yeah, this is, if we had a picture of what we all envision to be the classical menstrual curves. In other words, throughout a menstrual month, how high is the estrogen and how high is the progesterone and how high is the testosterone? It looks different than this. I was trying to pull up an image of that just moments ago, and I can, to show you what that looks like. But what we did is we looked at the
You want me to get out of this, and you want to do it on your computer?
If you can just hold that for a minute. What we did is we looked at the actual numbers, the actual amounts of progesterone that are secreted throughout a cycle. And this is what the numbers actually tell us. And take a look at that. You see a certain amount of estrogen there. You see a certain amount of progesterone all throughout the cycle. And it just shoots, the progesterone level just shoots up there mid-luteal. It's just an illustration that progesterone is present in very rich amounts, not only throughout the cycle, but especially in mid-luteal. And if it's okay, I'd like to make a comment that made me think about another way to look at this progesterone. And it came from my women patients, because back in the day, when I began, I was figuring this out with women patients. And as far as cycling progesterone goes, for example, I'd have women in menopause or women in perimenopause that were having symptoms of low progesterone, and we give them progesterone, and I would suggest to them that they do it like their body does it. Take the progesterone the last 2 weeks of your cycle. And the women would come back to me on follow-up, and they'd say, wow, the last 2 weeks of my cycle, my PMS has gone away, my anxiety's gone away. Really like this progesterone. Would there be anything wrong with me taking it during the first part of my cycle? And what did I know? I didn't really know. I knew what the physiology looked like, but I said, yeah, well, sure, why don't you do that? And this is what they would say, woman after woman after woman patient. Well, I already have done that, and I'm telling you, I feel great all month. So however else you want to look at it, progesterone really matters. And cycling in a perimenopausal and a menopausal woman, yeah, you can do some of it. But like Carol said, you want to take it every day. This is not something you really need to cycle. And Carol, maybe you'd want to elaborate on that.
I just want to ask Dr. Papanek one thing before we go to Carol. You had one other study that talked about the efficacy of delivery mode on breast tissue, and I was wondering if you can share that, and then we'll go back to Carol, unless anybody else wants to chime in. I think we're doing a nice little rhythm here.
Yeah, sure. So kind of just digging into this a little bit more, and I know Dr. Berkson kind of speaks to the pre-surgical progesterone studies that have been out there. A really neat one that I found, James Fodart, in 1998. He was kind of looking at the estradiol, again, E2, and progesterone topical. Again, we're using topical. And he was putting the compound itself actually on the breast tissue. Probably not something any of us would recommend. But again, it really doesn't seem to matter in terms of...
So in Europe, they do it that way, right?
Is that right all the time?
Yeah.
Okay. So it's not something I typically recommend to my women. Sometimes the progesterone just to kind of help with some of the cooling if they do have that tenderness from time to time. But regardless, his study looked at the topical application onto the breast tissue, and he had 4 groups: 1 placebo, 2 estradiol alone, 3.5 milligrams, 3 progesterone, bioidentical, body identical progesterone at 25 milligrams topical, and then 4th would be the estradiol and the progesterone group together. And what he found was, well, actually, these were prior to surgery. These were patients, 40 patients postmenopausal prior to surgery, not for breast cancer or nothing of that sort. This was for cosmetic. So he just was kind of investigating this. So the architecture of this breast really should have been okay, right? Because we weren't having any sort of disruption there. And he had them use this daily. So one of those 4 daily for about 14 days. On day 15, time of surgery, he did a couple things. Number 1, he drew estrogen and progesterone levels. Well, as you would imagine, of course, placebo was little to none. Remember, these were postmenopausal. The estradiol group had higher estradiols. That makes sense. So again, we're proving that it is getting into the system. We had topical, we had homogeneous, if you will, absorption in the systemic system. And then obviously the progesterone group had higher progesterone, so that was marked as well too. And the estradiol and the progesterone group obviously higher both. But what he also did at that time is he took biopsies of the breast tissue. Again, this was normal architectural breast tissue at that time, and then looked at different markers in terms of cellular turnover, like you were talking about, Dr. Rosensweet. They looked at cyclin, they looked at mitotic activity, they looked at anything that might be looking at the overall cellular turnover in attempts to, again, we don't want a lot of activity in that breast. We just don't want a lot of that. And interestingly, what he found was the estradiol alone, so the women that were just putting the estradiol alone on their breast days 1 through 14, had significant stimulatory proliferative mammary breast cell formation. So changes in that cell, there was proliferation within that. Interestingly, though, when they added the progesterone to it, so that combo group that had both estrogen and progesterone, it completely counteracted it. It brought it back down. Progesterone had kind of a counteract or an antagonist effect on that tissue, bringing it down to a nice, calm, cool level. And you didn't see that level of proliferation that we can see with the estradiol alone.
So topical progesterone protected the endpoint of the breast.
So cool. So cool that they were able to see that at the cellular level and kind of looking at that proliferation and such too. So a pretty neat study, not only showing topical, but also kind of that localization and how the progesterone really balances out, like you spoke, Dr. Rosensweet, that harmony and keeping them kind of in check together.
Holly, that was so well.
Would you post that link? That's a phenomenal article.
Sure, yeah.
You know, when I wrote Safe Hormones, Smart Women, there were about 100 articles at that time that looked at preoperative level of progesterone and then tracked breast cancer patients that had surgery. They looked at their progesterone levels before they went into breast cancer surgery. And they tracked them, some of these studies, up to 20 years and compared them to matched cohorts. That means women with similar tumors, similar age, people with similar characteristics, and women who had at least 4 nanograms per milliliter. If they had, you could see they had progesterone in their blood, it was near the mid-luteal phase, they tended to have less recurrence of breast cancer. If they did have breast cancer come back, they tended to die from it less. This was something very clear cut. And there were multiple, I know, Carol's, you've commented, you've saw these papers. And now most of these papers are gone in PubMed. They're buried because in 2011, an article came out saying we know progesterone prior to going into breast cancer surgery protects a woman in her life for years to follow. So we should now recommend this injectable synthetic progestin. And once that study came out suggesting that you use a pharmacologic form of progesterone, because we know progesterone is such an anti-cancer hormone, a lot of those other studies went away. But for all my breast cancer patients, I recommend that they go on progesterone at least for 2 weeks. And we know that topical is protecting that endpoint. Carol, did you want to comment on that?
I had the occasion, which was very interesting. So this is only an N of 1 woman with large breasts, very painful breasts, and she started using progesterone. She was using 400 milligrams a day. I was talking with David Zava at the time. Dr. Zava had a lot of experience with breast cancer for about 18 years prior to him having a hormone testing lab. Well, this particular patient had numerous biopsies, and she sent the results to Dr. Zava, and he said when she had a biopsy and she was using the progesterone, you could clearly see the cells starting to differentiate and improve.
Differentiate means they're healthier.
Right. They turn back into the healthy cells they should be. And the irony, of course, is we spent a lot of time with her, both of us, and Sloan Kettering convinced her to have her breasts off anyway, and she gave them $5 million. So this is so horrible. They created enough fear in her. And even though she had evidence that progesterone was turning around the whole thing, they were able to convince her that no, she was still at huge risk.
Do you use progesterone in your breast cancer patients? Recommend it?
I have had one patient that I can say for sure she used progesterone and her estrogen all the way through her treatment. She's clear now after 2 years. She went to Mexico, did a lot of other things, never quit her hormones, although she was advised she shouldn't have any hormones, and she did beautifully.
You know, that study that Holly was just talking about where there were the 4 periods, estradiol, wouldn't it have been interesting to have one of those, another one added where they used estradiol plus estriol, because estriol signals the anti-proliferative receptor in the breast. And what most of these studies do is look at estradiol that has a tendency to signal more the ER alpha or growth. And I haven't seen any studies really looking at, except for Yanaki talking about it, who discovered that second receptor. Anybody have any research on estradiol added to estriol working a little similarly like progesterone?
You won't. Who's going to fund that?
Carol, was your patient the patient you're talking about, was she on estradiol or was she on Bias?
Estradiol.
She was. Okay. Just curious. Yeah.
So does everyone here usually recommend Biased versus estradiol?
I like estradiol when you're older, actually. It has more profound effects over estriol for brain.
But what about the combination?
And the bones. So I would use much less estriol than the 80-20. I might flip that to more estradiol, less estriol. My concern is the brain and the bone remodeling. Estriol does not do that. So I think that's one of the negative aspects of this.
Actually, estriol does signal. ER beta is all over the brain. It's all over the brain, and it lines all the endothelium of the entire body. So we used to think that estriol didn't have much to do with bone and brain, but it does. But I like the combo of both, and I like to use both robustly because there's so many anti-cancer, anti-inflammatory benefits of estriol. But you're the second person. Somebody just a few weeks ago said estriol doesn't really have protective brain action because it doesn't have a lot of receptors in the brain. And I'm publishing soon my next book on oxytocin, and I show where oxytocin and estrogen receptor beta, the second estrogen receptor that estriol signals, are all over the brain and how they're on top of each other, and how estriol calms the brain, helps maintain the right volume and modeling of the tissue of the brain. So it's been an old thought that estriol wasn't very brain and neuroplastic active, but I'm here to report good stuff.
However,
And
it doesn't mean if you use estradiol, your liver's going to convert it to estriol. It doesn't mean you're going without. And
we have a great, we just did a whole podcast talk about this to biased or not to bias. So, there's people who say use estradiol, but Dr. Rosensweet, actually, he might talk a little bit about this. He did.
he's pro-biased.
Well, he did. And Dr. Rosensweet, do you want to chat about your research about?
Yeah, many years. I started out using biased in the early 1990s and was very happy with it. And then I got some feedback from a colleague that I trusted that I didn't really need to give bias, that all I had to do was give estradiol and the body would convert it to estriol just like it does in a young woman. And so I converted my patients from bias to estradiol, and because we've been doing serial 24-hour urines, I got to see in living technicolor if that theory was correct, and it was incorrect. There wasn't a single woman that we treated with estradiol alone that produced nature's ratio of estriol. I didn't convert it at all. And I promptly, it took me about a year to get all the results in, switched back to biased and love biased, and then it's the only thing I'm willing to prescribe, except to my own mother. Who
what do you mean by that? Why is that?
My own mother, by the time she let me treat her, she was not cognitively capable of doing topical. And so I gave her oral estradiol. So
we have a number of questions. We only have 10 minutes left, so I think I'm going to go over to the questions because it might take this time. And let's see, that's your answer there.
I think there's a couple of statements, but they're not
they're statements. They're not questions. Okay, then we don't need to worry about that. So we can go back to our discussion. People were making statements about whether they use bias or estriol, et cetera. They were chiming in, and we appreciate that. We appreciate you all being here and everyone taking time out of your busy schedule to really address this. So I'm going to go through every person on this panel. Tell me whether you think oral, topical, vaginal address all three delivery modes, and do you think they protect breast or endometrium? And we know they do other things, but I'd like each person to go through and give your commentary on that, because that is the question of the day. Which delivery modes, if not all, or if any, protect breast and endometrium? And we'll just go over here to the left. And so Dr. Holly Papanek, what do you think?
So for all of those, my answer is yes. And it depends on individuality and the care of each individual patient. So the dose, I don't know, but that's easy enough. I can measure it. I can do blood testing, or I could do 24-hour urine, which I love very much. And then I can tell you, is it protected or not? Worst case scenario, I do additional testing, whether it be a transvaginal ultrasound to prove that the stripe is thin, or, there are other breast and such studies that we could look at in terms of, are we getting too much hyperproliferation, or is there too much estrogen as opposed to progesterone, and kind of the management of that. But all of them will work and do work. And I use all of the different modalities that you said. I use oral in some, I use topical in some, and I use vaginal in some as well, too.
Do you ever use a combination?
Absolutely. A lot. I typically start topical. I love the fact that once it's absorbed through the skin, it spreads out through the blood system, hits all the receptors it can possibly hit before it finally gets to the liver and is broken down. That's my preferred, because I think that's as close to nature as I can probably get, at least at this point, or mucosal, vaginal, obviously very similar.
And we just had a question. What do you feel is the ideal endometrial stripe in millimeters of mercury in a menopausal woman? There's the 5 millimeter mercury people, and now there's the 4 millimercury people. And there's the 3. It reminds me of Clay and that old Flash Gordon and the Clay people. It reminds me of that for some reason. What are your thoughts on the ideal thickness of the lining of the uterus in a menopausal woman?
I think there's a primary consideration, and it's that it's uniform and that there's no bump or lump in there that would suggest endometrial cancer. That's what we're really looking for. 5 millimeter, 4 millimeter, 3 millimeter. No lump is what I'm saying, and less than 5 is optimal.
Okay, so Dr. Rosensweet, What do you say about the 3 delivery modes and their protection of the 2 endpoints?
I haven't used vaginal, but I've definitely used oral and topical, and I like them both. They both work. It depends on the individual woman. You can get a woman symptom-free and no excessive proliferation with both methods. And it's dose variable, like so many on the panel have already said. You got to figure out each individual woman what's optimal for her. But either one, I like oral.
And remember, the heavier the woman, you're going to need more to go through because she has more degrading progesterone enzymes. So in fact, that's the case for many nutraceuticals. All the fat-soluble vitamins, people that carry a bit more weight need them. So we're always individualizing all of this information to the personal patient. Jill, your comments on the delivery modes and the endpoints of the breast and the uterine lining.
Yeah, so I mean, I agree with Dr. Rosensweet and Dr. Papanek. I don't see patients or do vaginal ultrasounds, but over the years, I have worked with providers that do same thing. And again, I think it comes down to dosing as well and the individualization, because we've had women who have been on oral progesterone and have had bleeding, right? And so maybe they need a tweak to that dosage or adding vaginal progesterone, or maybe they need topical. So I think it is just so variable woman to woman, but I think all 3 absolutely can protect.
I love the vaginal delivery. I've actually had people that have polyps, people that were told they have to have a hysterectomy stat because they have a really thickened endometrial stripe. Application of vaginal delivery within 6 weeks often gives you a normal transvaginal ultrasound. I mean, it's that rapid. So if you want to get in for polyps, fibroids, endometrial thickening, and you want to do it stat, if you deliver, it super saturates tenfold in like 30 seconds the level of progesterone in the uterus. And progesterone causes anti-inflammatory cytokines. It tamps all the inflammation down. And if the fibroids are small enough, it might even help reverse some of that. But fibroids end up getting their own blood supply, so they can be very, very squirrely. But I actually had a patient who had a horrible experience with a surgery a number of years back, and she was diagnosed with very early stage endometrial cancer, and she did not want to have surgery. She just refused to have surgery. So we actually gave her progesterone vaginally 3 times a day. We had a doctor in her area in Nashville, a gynecologist who was willing to monitor her with transvaginal ultrasounds and other imaging. And this is a crazy, crazy story. We made her sign all these disclaimers because we all wanted her to have a hysterectomy. Everybody said you should have a hysterectomy, but she would not have a hysterectomy. So within 9 months, she was completely free of cancer. And I keep getting Christmas cards from her every single year. I got them last year. I haven't gotten it yet this December, where she's still cancer-free and is doing great. We did add some 2-methoxyestradiol to that vaginal progesterone, by the way. It's that end metabolite of estrogen that has actions almost like a chemotherapeutic medication. It's crazy. But anyway, I just thought I would mention that. And Carol, it's your turn. So what do you think about the different delivery modes and their effect on breast and uterine tissue?
All of them work. I always say it's the hormone. It's not the delivery system that works. And I'd like to put one more little caveat, because you brought in fibroids. Underdosing progesterone can have a kickback effect and more stimulation. And if you're treating fibroids, you need to go right to some big doses, or you allow the fibroids to grow, which you don't want to do.
Like what kind of doses, Carol?
I'd go to like 300-400 for sure, oral, topical, whatever, bigger doses, just to ensure that fibroid's not going to grow. Years ago,
there's some articles that show that progesterone makes them grow, but it's the synthetic progestins and not the natural, as long as you have it in the right dosage. So that is the problem with reading some of these studies, right?
Yeah, no, natural will do it too. And this comes from Dr. Warshawski, who's published a book on treating fibroids naturally. He said personally, sometimes the progesterone's making those fibroids grow. I said you have to use more than you're using in that particular patient. So something not to be ignored. I always give that caution. On endometrial cancer used to be treated with progesterone. We've had a propaganda switch to make everybody want to have hysterectomies given, and it was about a 50% success rate with endometrial cancer. to use progesterone. So progesterone, any way, shape, or form you can get it in, so your patient absorbs it and will use it. Is my bottom line.
Progesterone works against so many cancer cell lines. It's quite an extraordinary, it works very similarly to estriol, working against multiple carcinogenic cell lines. It's really quite extraordinary. There were some questions now that have come up, so I'm going to go to these. So we're almost ending the hour. Carol Brinkman, let's see, for what should the endometrial stripe actually measure? If the endometrial stripe is greater than 5 millimeters, what does this mean, and what is recommended to do differently, if anything?
Can I ask if you guys, is everybody doing, I mean, I think what I've always learned, and probably from you, Dr. Rosensweet, is really during perimenopause, we are going to have those changes in the endometrial stripe because of endogenous production of hormones. So is this post-menopause? I guess maybe so we can clarify there, because it will change, obviously, depending on whether this is peri or post-menopause, right? We have more of an acceptable level of maybe a thicker stripe depending on when a woman is cycling. I
think we're talking now about postmenopausal women.
Okay.
Yeah. So, I think you can just add more progesterone. But, if there is a lump or a bump that Dr. Rosensweet just said on that vaginal ultrasound, you've got to have that. You have to know what that is. But usually that means that the balance, there's not enough progesterone or there's too much estrogen. So the balance of that. Does anyone else want to say anything to that?
Yes, the first thing I do is use progesterone, and a lot of it continuously until it's enough for progesterone to have its secretory effect and you bleed. And warn your patients, you're going to bleed. You're going to have a heavy bleed. You can continue that progesterone during bleeding to make it more efficient. If you say, oh, I'm going to stop, then the bleeding will not continue as efficiently, and you may have spotting for weeks if you drop down the progesterone. So I prefer to warn women that you're going to have this bleeding when you start progesterone in adequate dose, and that's a good thing. You've gotten rid of the old stuff, and sometimes these women see dark brown blood. It's not the fresh looking usual blood because it's been sitting there for a while. You want it out, and you can get it out with progesterone. And then from there, you go forward and try to keep the balance with estrogen, progesterone.
Next question, and thank you so much for that very clear answer, Carol. Everybody's doing such a great job. Next question, what is the biggest difference between prometrium and compounded progesterone? My preference is compounded. I do not like the limited dosing of prometrium, and I also don't like it is in peanut oil.
And dyes that you may not want.
I posted what's else in there, titanium, dyes, Carol was saying, yellow dye number 10, red dye number 40. I don't know.
And aren't red dyes linked to an increased proliferation of breast cells and potential risk of breast cancer? Isn't that crazy?
Yeah, why even do it that way? Certainly they had enough expertise to avoid all these toxins. It's
and peanut lectins, there was a study that came out last year. Peanut lectins are unique in that they can take cancer cells and help them travel throughout the body, promoting metastatic activity. And that's what kills you with cancer, is traveling cancer cells. And there's something unique there's nothing wrong with having peanuts once in a while, but if you're taking progesterone daily, do you want to take it with a lectin that can carry cancer cells far and wide? I think not, right? Next question.
I'm going to have to sign off.
Okay. I guess we're going to end it now then. Let's just end it and thank everybody. I know we just said an hour, so we're at an hour and 4 minutes. I can't thank you enough for clarifying that all 3 delivery modes, oral, topical, and vaginal, reach the breast, reach the uterus, and protect them so we can have peace of mind. That's what this is all about, to take your bioidentical hormone replacement in an effective but safe manner that gives you peace of mind. I want to thank all of you for being here today. If anybody has one last sentence, you're welcome to say it. If not, we will bid a progesterone adieu. Thank you, everybody.
Thank you,
Blessings.
Devaki.
Have a great holiday.
Thanks for organizing this.